What's going on, guys? Dr. Andrew Fix back here for another episode on the code. Thank you so much for tuning in, joining us, however you are listening to or watching this podcast today. We really appreciate your time and tuning in. We've done this a few times on this show, but we are pleased to welcome back a guest that we've had on here before, Dr. Emily Splichal. She is a functional podiatrist, expert in human movement, and she is the CEO and founder of Naboso. Dr. Emily, thank you so much for coming back on the code and joining us for another conversation.
Of course. Thank you so much. And it is always a pleasure.
Absolutely. Well, thank you. What I would love for you to do, especially if someone hasn't had an opportunity to hear the first conversation we had, we were just talking about that being almost 2 years ago. So sometime in like 2022, I think it was, we had a conversation. We talked all about kind of the foot and how we can improve the function. But if you could give us another introduction of yourself and let's just start there. Tell us about you.
Yep, absolutely. Sounds good. So you had already said a little bit, but I am a functional podiatrist. That is an important distinction for the listeners, that the way that I look at the foot and the ankle is from a very integrated perspective. In fact, I actually get most of my patients out of their orthotics, out of supportive shoes. I'm trying to get them to find the natural strength of their foot. Also, part of my role as a functional podiatrist is that I factor in stress levels, diet, sleep. So very systemically looking at and considering what could be influencing the presentation of the patient. I also have my master's in human movement. That is very important for the type of patient that I see in my office, which is oftentimes chronic pain, chronic movement disorders, chronic movement dysfunction. Oftentimes they've exhausted seeing multiple providers before me. So they want someone who's going to take a step back, think outside of the box. And then when I do patient programming, I take a very sensory-based approach. That's part of why I founded Naboso, but always thinking of how can we increase and optimize or integrate sensory stimulation into any exercises that they may be doing, rehab, or throughout their day.
Man, and I think that's one of the reasons that we connect so well and why I want to have you on here and have this conversation because somebody recently asked me, like a client here locally, do you have any good foot specialist recommendations? Do you have any podiatry office recommendations? I want to send my dad or I want to go to the podiatrist. And generally speaking, that is often a very hard referral for me to make because I don't see our office aligning very often very well with the podiatry office because we take an approach just like what you said. We're trying to get people's foot to function, get them out of the thick cushiony shoes, the narrow toe box shoes, out of the orthotics. And that's exactly the opposite of what we see in the typical podiatry office. Why do just being someone that practices in this way, why do you think that is? Like, why is that the direction that the typical podiatry office goes and that we have to go a route that, you call functional podiatry to get away from that norm?
I wish I had the answer.
Yeah.
Just kidding. No, I went to podiatry school coming from the fitness industry, and that's another part of my history that I didn't mention, is that I've been in the fitness industry for over 23 years,
Yeah.
which means that I came into podiatry school with an appreciation for movement, for exercises, for programming in a higher level that maybe the average podiatry student doesn't have. So then we are taught from a certain perspective or lens, which is a very old lens, a very kind of old school, narrow-minded perspective. And then it literally just keeps repeating itself generation after generation of what is taught in school. When I was going through podiatry school, and I'm East Coast trained, which is important in the space of podiatry because West Coast trained is actually more forward thinking than East Coast as far as podiatry goes. But I started to ask myself and say, well, is that really the case? Is that exactly the shoe that I would recommend? Like, why am I recommending that shoe? Just because my attending taught me to say that shoe is the answer. And I started to just question things. And perhaps that's just my upbringing and part of just my deeper personality. But then I also, when I was going through my surgical training, I took a break and I went to get my master's in human movement. So I kind of zigged and zagged in my career. in that master's, I learned a lot about human movement that I would never have learned in podiatry school, actually in medical school in general.
Yeah.
You could probably even argue in chiropractic and physical therapy that I was immediately brought into this different perspective. And then I took it upon myself to learn through fascial experts, breathing experts, pelvic floor specialists,
Mhm.
trauma specialists. So all of this stuff, so I could bring a very integrated approach to my patients.
Yeah, I think that is so important because what we know doesn't work as well is having like all these different facets of health and of how the body functions all siloed out, right? Like we need to incorporate all of these different pieces and have different professionals if the person's working with multiple all on the same page, hopefully speaking a similar language so that we can ultimately address the root causes of what's going on with people instead of just slapping treatments or throwing treatments at a dartboard to change symptoms or to manage symptoms that people are dealing with. And anyone listening to this podcast has heard me and the other guests we've had on here talk at nauseum about that. Why don't we steer this conversation today, knowing that like we both come from a big background in fitness, and we try to take this root cause functional style approach in the care with our clients. And let's talk about some of the like most common ailments that people are often dealing with as far as the foot and the ankle are concerned. And, I would love to hear from you about some of these things. And I think the three that we hear probably the most common in our office are recurrent Achilles tendon complications, or like Achilles tendonitis, or probably more commonly tendinopathy being a
Mhm.
big one. Plantar fasciitis being a big one. And I sort of like chuckle at that one because I think oftentimes people come in with foot pain and they tell us that they have plantar fasciitis, and it's not often plantar fasciitis, or it might be a referral from the lower back, or it might be one of the other many things that are going on in the foot aside from the plantar fascia that it could actually be the problem too. And we sometimes find that when we start really diving into an assessment. And then shin splints or medial tibial stress syndrome is another one, and that's where we end up getting in this conversation about somebody's been told for years that they need to wear orthotics and their foot is overpronating and X, Y, and Z, and sometimes breaking that belief is really really challenging for people. Is there one in particular that you would love to start with if we sort of focus on those three things?
Yeah, I would say probably the plantar fasciitis, or let's just call it heel pain, so we keep it a little bit broad of what that diagnosis could be. What I can definitely say is that, similar in my experience, is that if a patient writes down what their chief complaint is or why are you here, and they write plantar fasciitis, it's only human nature, even as a medical provider, to start to see the plantar fasciitis because of the patient writing that down. So
Yeah,
it's
sure.
really important to make sure that all heel pain is definitely not just classic plantar fasciitis. What are the differentials? And even if it is,
Mm,
what is the root cause of that? And that's very important for when I'm doing an assessment. So one of the aspects of plantar fasciitis, how I like to describe it from a human movement perspective, is every time we walk, we strike the ground, or when we run, we strike the ground, we are experiencing ground reaction forces. And those impact forces are perceived as vibration. And that vibration is an important stimulus to our nervous system, to our muscular system. It's what builds bone density. However, if you cannot control those vibrations entering your foot and your lower extremity, it's essentially going to dissipate into the connective tissue and into the bones, which could also explain some of the shin splint story. But if it gets into your plantar fascia from excess or uncontrolled vibration, this is a cause of plantar fasciitis that is often overlooked.
mm,
Now, part of how we absorb impact forces is based off of contracting our foot muscles.
mhm.
When you contract your foot muscles, you create a stiffening response on the foot and ankle, but stiffening response.
Yeah.
I often will explain it similar to like a tuning fork.
Hmm.
So if you imagine you have a tuning fork and the tuning fork is vibrating, how are you going to stop the vibration of the tuning fork? You essentially touch it, or you clamp into it, you contract, you stiffen around the contracting tuning fork or cymbals vibrating.
Yeah.
Think of that same thing. So you have to stiffen the foot through contracting your foot muscles. Now, a flat foot or an overpronated foot has a little harder time. It's a slow foot.
Hmm.
So it's a slower foot that does not sufficiently stiffen upon strike and vibration entering. So this can be a common contributor to plantar heel pain. Now, is it plantar fasciitis? Maybe. Is it a periosteitis, which is just more the saran wrap of the heel bone? Okay, right? So that's part of where I start to think of heel pain
Yeah.
is from the stabilization, the ability to stiffen the foot strength, the isometric foot strength, and then everything becomes timing. So
Yeah.
how quickly can you do this mechanism over and over based off of the activity that you're doing?
Yeah. Yeah. Because really, no matter what activity we're doing, our foot, I mean, I guess unless we're swimming, but then even still, your foot's touching the wall or you're diving off of the blocks or something. But like your foot is your main first interface with the ground. And you're going to be taking hundreds of thousands of steps over the course of these runs and, gymnastics events or basketball or whatever it is. So yeah, it makes sense that if we have some sort of a dysfunction in how we absorb that force from the ground and how we manage that could lead to problems.
100%. Now, a different another mechanism for irritating the plantar fascia could be very much based on arch compression.
Mhm.
And arch compression is another one, which is probably one that the listeners would be more familiar with, is if you think of the plantar fascia as like a rubber band, and every time you step on the ground, you are essentially loading or lengthening the plantar fascia as you go through the mid stance position of the foot, right?
Mhm.
So you're kind of loading it or potentiating the fascia. Based off of the hydration and the elasticity of the plantar fascia, if it's insufficient, you will then start to micro tear the fascial fibers at its origin, which is at the heel. And then that micro tearing creates a injury response in the body, which then creates some disorganization of connective tissue. You get neovascularization, you get disorganization, collagen type 1 is replaced with collagen type 3, blah, blah, blah. Essentially, I explain to patients, it's like a haystack. It's just a chaotic haystack because of the injury cycle that is oftentimes perpetuated from non-compliant patients, just kidding, but from just this remodeling repair phase keeps getting a little bit disrupted, that it doesn't get to do a full clean process. And then that's where we get these plantar fascial symptoms. That's another common one. But oftentimes, a lot of that and the elasticity and the timing of the stiffening and the arch compression is because of insufficient stability or stiffening in the foot.
Yeah, I love that. And I think I like where we're going with this conversation because so often I feel like we are taught, as far as the foot goes, what people are taught is we need to control all motion, right? We need arch supports, we need motion control shoes, X, Y, and Z. But you just brought up the word stability, and stability does not necessarily mean we don't have motion. It just means we're able to control it and go through it at a rate that is appropriate. Um, and I feel the exact same as you that plantar fasciitis is often a lack of stability problem, not a lack of motion problem. But so often I feel like the prescription, and I'll use air quotes on that because I don't know that it's a good one, that clients will tell us that they've been told to do when they do get diagnosed by somebody with plantar fasciitis has nothing to do with stability. It's stretching your calves, it's wearing orthotics, it's wearing high cushion shoes, and it's nothing that produces stability, right? But you're saying we need that stability in order to potentially not suffer from a problem like this.
100%. And that's where I go back to timing. And a lot of people don't think about that. So it's more about what is the timing of the pronation. We all need to pronate. That's how you unlock and load energy when you move dynamically. But what is the timing of that? What is the deceleration of that unlocking? And that's really, really important. And that's oftentimes the overlooked piece. Now, what I will mention is that at times I will use arch supports. And what I will explain to the patient is that I consider this putting out the fire. I
Hmm.
am just trying to get control of the situation. And this is very important so that I can help guide them through the remodeling phase of this local injury.
Yeah.
So that's the other part, right? So we have a local injury, and then oftentimes you have a global loss of stability in the system, in the timing of the feet to the hip, to the glutes, to the pelvic floor. The system has lost its integrated stability.
Yeah.
But what's happening locally, and I think that's important to think about as well, is okay, we've got a local fire that I need to put out and control the situation while simultaneously understanding the global systemic or the chain, the fascial chain loss of stability or delay in stability.
Yeah. Yeah. I like that. And, it's such a system, right? It's like the answer is not always just in the foot.
Mhm.
Um, Now, I was listening to something earlier. This was specifically about back pain and deadlifts. However, um, one thing that we know is back pain is so darn common. Well, foot pain is really common too. And a lot of times when somebody comes into a clinic, a physical therapy clinic, a physician's office, whatever it is, with back pain, the treatment is often not strengthening of the back, right? It's we strengthen the hips, we strengthen the glutes, we strengthen the quote unquote core, we do abdominal muscles, but are we actually doing strengthening of the back? And it can often be said that like back pain is also called as like weak back disease, right? A weak back is often a painful back or a symptomatic back. And I think the same is probably true for our foot. Like a weak foot is probably often a foot that's going to be more prone to pain or symptoms.
Absolutely, 100%. And
Yeah.
that's where I like to teach foot typing. Like, one, let's just understand, and the patients or the individuals, all the listeners should just have a good understanding of what is their foot type, and then what are generalizations of what that foot type means.
Hmm.
And it is, you have to do a foot assessment in a very specific way if you're doing it to yourself, where you have to stand in front of a camera, behind it. Many people are told incorrectly by their podiatrist that they have flat feet. And then I see the patients, I'm like, oh my gosh, you do not have flat feet. I have no idea where that came from. And I'll take pictures and then I show them and I explain so that they actually understand the foot posture and what that means. Another thing that I'm doing a lot lately is to help people to feel their foot pressure.
Hmm.
So passive foot pressure will indicate foot posture. And through that, I'll have people just stand nice and relaxed. I'll have them shut their eyes, and then they're just going to notice, do they have more pressure on one foot versus the other? Is there more pressure in the heels or the forefoot? Is there more pressure on the inside or the outside of the feet? And they're just checking in,
Yeah.
right? And if you have more pressure, let's say on the outside of your feet, well, then that'll be a supination or an inverted moment, right? And then just what does that mean? What does that do up the leg? So if you have a lot of IT band issues, then, oh, that makes sense that every movement of my foot ultimately is affecting
Yep.
legs, knees, hips, pelvis. And I want people to really connect to that and understand what that means.
Yeah. And just to be clear, when you say a supinated moment, are you using the word moment in like a physics sense of like we have more torque going in that direction?
Yeah. So just it's a moment in time
Yeah. Okay.
because I try to also think of things very dynamically and not be, you have an overpronated foot and like try
Yeah.
to, there's these generalizations that everything is fluid, right? And posture is fluid, movement is fluid. So I
Yeah.
try to not come to these very polar conclusions when I assess patients and movement and just say, maybe today you just have a little more valgus moment to your knee. That's it, right? What is it doing, right, etc. So I try to make it a little more fluid.
Yeah. No, I think that's good because sometimes, we can get too rigid in believing all one way or all the other way. And, we know it's not typically that. The answer lies typically somewhere in the middle, or more one way one day, more one way on another day.
Yeah.
For um without trying to oversimplify things, knowing that every person, everybody listening to this, every client that comes into an office is going to have their own unique things going on, and we have to individualize that treatment approach to them. Generally speaking, if someone is dealing with plantar fasciitis or heel pain, like we just were sort of talking about, what is a very common trajectory of treatment? Like, what does that treatment approach typically look like for somebody if somebody listening to this is or knows somebody that is actually dealing with that?
Yeah. And my answer to this is going to fall into a little bit of your Achilles, little shin, maybe a little post tib.
Yeah.
Let's keep it kind of broad in the apathy that they might be feeling, right? Or if the listeners really connect to the plantar heel pain, then let's just say heel pain. But so what I try to do, and this is where I start to flow into this getting control of the situation. A lot of it is going to start with understanding what type or time frame are we talking about? And that's breaking it down into acute versus chronic, so that I, as the provider, or for any provider, is to start to understand what is the connective tissue state. That's why I ask a lot of questions as far as time. How long have you had your symptoms? Textbook is less than 6 months is quote unquote acute, more than 6 months is quote unquote chronic. Although I like to probe and just say, have you ever had this before? Have you had this, 10 years ago, 5 years ago? Does it flare up every year for the last 5 years and you just get it for like a 6-week flare up
Yeah.
once a year for 5 years? That tells me a different story than if you've never felt this ever before in your life and now you've had it for 8 weeks. I understand the tissue has a different presentation to it. Once I have that classification, regardless, I put everyone in a 2-week putting out the fire program. And this putting out the fires for me to, again, understand what is the state of the tissue. So it's navigating almost like choose your own adventure books. This is me choosing my own adventures, right? Based off of this, is going to do some sort of support. And I will put patients transiently. Remember, this is transient, this is for 2 weeks, putting them in something, let's call it an over-the-counter arch support, just for the sake of this, or an elastic arch strap, or maybe we'll do some taping. I don't know what it is, but it's falling under support to allow the tissue to time out.
Just
Time out, everyone, right? That's the support. Then it's going to be stress, meaning minimizing tissue stress. If you have plantar fasciitis or plantar heel pain and you're still doing deadlifts at the gym, you cannot do those. Those are going to strain your posterior chain. You cannot stand for 12 hours at work. Like, how do we navigate that one? You cannot run, you cannot do jumps. You have to really try to pull as much of that impact gravitational stress or strain that you are doing during your day. Third is going to be some form of body work. Is it going to be releasing the bottom of the foot? Is it going to be releasing the soleus? I always go peri or around where the pain actually is. You don't go on the side of pain, of course. Are you doing dry needling, Graston? It's a bucket. And then the fourth one is that I'm a big fan of systemic enzymes. I will, in certain situations, prescribe like Mobic if someone is super non-compliant in the supplement side and they're like, I need something once a day, easy. My lifestyle just doesn't work with something. It's just part of the story, right? I like photobiomodulation also in that fourth one, but we're just doing something for the potential immunoinflammatory cycle that they may be in. And I do that for those 4 steps for 2 weeks, every single day. Then we reconnect and we just say, where are we at? If you were an 8 out of 10, are you a 5 out of 10? If you were a 5 out of 10, are you a 2 out of 10? Like, I don't know. Or are you literally exactly the same? And then from there, my flow chart would either go into starting to look at global systemic stabilization contributors. Is it looking at just continuing the course? We just need a little bit more time. Is it ordering imaging to make sure that there's no partial tear of the plantar fascia? Is it a neuritis, not a plantar fascial? What is it? But that's how I'll start to differentiate, because what I've just found from my clinical experience is even some of your chronic plantar fascial symptoms kind of textbook chronic will actually respond to a very compliant, controlled, local putting out the fire.
Yeah.
And then we can do it. So we don't have to jump to assuming that there is massive degeneration to the connective tissue. So that's why I try to do that 2-week putting out the fire for all of them, regardless of the time at how they presented.
Yeah. Yeah. And I kind of like this. And, of course, I'm a little bit biased here. We have this 3-step process that we like to preach for our practice at Physio Room. That's called reset, restore, reload. And it basically sounds like that's exactly what you're talking about. Like the person comes in, you do your thorough assessment, and the first step is like, let's reset things. Let's calm things down. Let's give some support where it seems like support is needed, deload that tissue a little bit, let the fire put itself out, calm down. And then we're going to restore. We're going to start to, you use the term PBM, photobiomodulation. So maybe we talk about red light for a second, but we do things that are going to help to restore that area of the body work, the dry needling, the tissue work, whatever that is, the anti-inflammatory and blood flow promoting things to try and help that area. And then this is ultimately going to result in going farther down the path of reintegrating the activities, strengthening stability, gradually loading and building back into the things that the person wants to do. And I think it's so important to know that like it is typically unlikely that we are going to completely resolve an issue for the long term unless we hit all of those categories, right? If we don't hit reset, restore, reload, we're not going to completely address this. And I guess I even hesitate to say completely address it because it's an ongoing practice that like has to keep happening. It's not like you finish treatment and then you just go back to what you were doing before and it's never going to come back. But can you tell our listeners a little bit more about red light therapy or photobiomodulation, if they're unfamiliar with that?
Absolutely. So photobiomodulation is one of my favorite areas under regenerative. So I put it under regenerative techniques. And as far as soft tissue goes, that it is, so let me take a step back here. So photobiomodulation was initially introduced through lasers within different practices, where it was cold lasers, class 4 lasers, somewhere you have to have the goggles because it was stronger. And that was a way to essentially deliver different wavelengths of light to then stimulate microcirculation, to decrease substance P, which is a marker of pain, to support the mitochondria. So there's a lot of tissue remodeling that was essentially popularized through red light beds and all the red light therapy. A lot of the red light boxes actually have red light and then near infrared. So they have a combination of these wavelengths, and the different wavelengths are applicable and powerful for different types of tissue. Near infrared, which I really like based off of just certain presentations, just penetrates deeper. So I like that for bone, is when there's something like a bone fracture or bone edema, I will definitely want my patient to incorporate near infrared into it. But the combination is what I will often recommend. Also has really good benefits for nerve tissue. So anytime I get a neuritis, a neuropathy, whatever the nerve-based symptom is, I will definitely incorporate photobiomodulation into that. Far infrared, which is what infrared saunas are, is again a different wavelength. So some of the wavelengths you see, some you don't see. And you don't have to see the light for it to be doing something for the body, right? And I like far infrared as well, but really the boxes is what I've started having a lot of my patients do, just because my practice is primarily virtual. So I had to be able to offer patients solutions that they can kind of do on their own at home. COVID kind of demonstrated that to us. And then there are some really good red light or photobiomodulation boxes that I will recommend. So I try to stay with certain companies that are well tested as far as what they're getting delivered. But it is a very important part of the story. And that's kind of what I call the whole program I give the patient, is it works in conjunction with everything else. And you need the whole story to then see the benefit of what we are trying to do.
Totally. Yeah, I think that's so important that like it's the whole picture. Are there some brands or types that you really like and prefer?
So I work with Mito Red Light. That's the one that I recommend. Some of the other ones where they're actually on the devices, there's some foot pads or they'll wrap around like the knee or the shoulder. Why I often recommend the boxes is that there's just increased utility.
Sure.
So just from a kind of lifespan of the box, right? If you're like, well, now my foot went away, my foot pain went away, and now I have this $300 box that I bought, and that is no longer usable, right? So having a box versus something that wraps around a body part is much more in the direction that I would like to go. I
Sure.
personally do 15 minutes of red light every single morning. And I've actually read some really good research as of late of what it does for the retina, and protecting vision is great. So I just started incorporating that.
Yeah, it just seems like it is continuing to grow and grow and grow in utility and popularity as we find out more and more about it. We have one of those class 4 lasers in each of our locations, and I know when I first came to Physio Room, I was very skeptical because I had not used one in the past. I was very skeptical about like, is this really going to work? But the number of client testimonials and personal use times that we've had where people do notice a benefit is just way too many to count that there is absolutely something to it. I think the sample size is far too large. So I think that'd be a cool thing for you guys to check out if you're listening to this. Um, so what about if we move into the, kind of the well, we talked about stability. I guess before we move on too much to Achilles, we talked about stability. What are some of your favorite ways to strengthen the foot? Like I know there's like we could go anywhere with this answer, but for someone listening to this, maybe they're dealing with plantar fasciitis, and maybe they're like so many of us that have a sedentary office job or something, right? They're sitting a lot. What are some of the lowest barrier to entry, lowest hanging fruit ways that they can start to incorporate some foot strengthening into their daily habits?
Absolutely. So the foot exercises that I'm going to recommend are all closed chain, which means weight bearing. I'm a huge fan of getting into the gravitational experience at which you are actually going to be loading the foot versus open chain. Doesn't mean that if you're post an injury or post surgery and you're doing some resistance band work that is not creating a benefit. I just want to say that if you had to choose something, I would try to be a standing or what's called closed chain as much as possible. Second thing with that is that you always need to make sure that your foot has a proper foot position before you do any foot exercise. Imagine if you were doing bicep curls or a squat or any other exercise and you had not good form. So you would not be activating the right muscles because you need to have the skeletal alignment to support the muscle contraction at which you're going after. So setting the base is what I call it. Finding a foot tripod is step one for sure. So find the foot tripod, lift and lengthen the digits. So proper foot function is based around long, straight, flat digits. Understanding and feeling how your rear foot rotates. So if you're everted and unlocked, you want to actually externally rotate your hips a little bit to lift the arch. And you can consciously do that and rotate your hips to lift that arch. And then from there, that is a nice stable base that you would then move into your foot exercises. Now, foot strength, as far as function, balance, pelvic floor, glute, a lot of that is actually housed within our toes. So I'm very much into toe activation. Anyone who's ever listened to me on anything that I've done knows that I love short foot. So short foot is going to be coming here soon. Short foot is a toe flexor activation, which means you are pulling your toes into the ground or anchoring your digits. That's essentially what the action is. Now, I started teaching it through an exercise that's called forward lean. Forward lean would be standing with your stable base, just as we described it. Arms are by your side, standing nice and tall. Imagine that you are stiff as a board. staying stiff as a board. You're going to slightly lean your body forward. And when you lean your body forward, you should feel your toes connect into the ground. So they'll anchor on their own through this reflex. And then you go vertical and you do that 5 to 8 times, feeling the activation of the digits every time. That is how I get people to feel what it feels like. Once they understand that, then you want to be able to push your toes down without leaning forward. So can you just anchor kind of on cue? That's the first way to do it.
Yeah.
Now, ultimately, strong feet connect to your core. So I cannot, in its deepest form, teach a foot exercise without saying, what are you doing with your breath? What is the timing of how you inhale versus exhale? What are you doing to your pelvic floor? So every time your toes push down, you theoretically want to lift your pelvic floor. Every time you push your toes down and lift your pelvic floor, you want to be exhaling. So that becomes integrated. You could do that rep-based. You could inhale and then lengthen your exhale. And as you're lengthening your exhale, you start to push your digits into the ground. You could do kind of like you're bounding or stepping off of a step. And as soon as your foot hits the ground, boom, toes push in, pelvic floor lift, exhale.
Yeah.
So you're integrating it. You can do it in balance exercises. So one of my favorite exercises for foot strengthening is a single leg stance.
Yeah.
Because you get a lot of intrinsic inside ankle, outside ankle activations. You're getting post-tib perineal activation, intrinsics through your digits. So that is, you're just hitting as many muscles as possible in a single leg stance. And then could you progress that to a single heel raise, not leaning forward, but really lightly, so you have as much body weight as possible, doing a single heel raise. That is a very functional movement of the foot that is often overlooked or actually never trained in someone, is the ability to do a single heel raise. And we don't realize that until you don't have the strength to get up the stairs, right? So very functional to be able to do that. Those honestly are going to be some of my go-tos, and then I'm going to integrate the body. So I don't need you to do towel crunches, pick up marbles, toe yoga, toe tap outs. I have a very boring list of foot exercises, but I'm going to get you moving and doing it different tempo, under load, different repetitions. So I play with that aspect of the programming, depending on the goal or the lifestyle of the individual.
Well, and I think I love that you went in a closed chain direction because especially if someone's listening to this and they're a client of mine, they're going to know that we spend the vast majority of our time doing closed chain exercises. Part of that is we don't see a highly post-operative client population in our office. We see a high recurrent chronic overuse type of injury group of folks. And they're not usually dealing with traumatic injuries, but more those insidious onset ones. And they want to still be doing their activities, right? We're going to move into closed chain. We're not going to be doing just clamshells on the table for weeks on end. Your foot is functioning when your foot's on the ground. So if all you're doing are exercises where your foot is off the ground and you are scrunching your toes, it's tough for somebody like me to see how is that going to translate into propelling you forward and absorbing shock and stuff while you are on your feet, running, walking, jumping. Important to clarify, I just want to make sure everyone understands when you're doing that short foot exercise or toe pressing down into the floor, or you're doing the forward lean, those toes are pressing down into the floor, but they are not curling and crunching up, right? They're just pressing down, not flexing.
Yes, 100%. And this, I will go very much physics. This is physics 101, that if you think about lever arms, so when we go into a push-off position, which is, for the listeners, if they did like a calf raise and look at your foot, even if you're seated and you do a calf raise, look at that position of the foot. That is called a rigid lever. That position, lever, is based off of creating torque around your MPJs. So the longer, the straighter your digits, you can then create more torque. Another area where we create torque is around the foot and the Achilles, so your ankle. And they've demonstrated that longer feet can obviously create more torque, longer lever arms. So here, digits, long, straight, and flat. And there's a lot of research around toe flexor strength and vertical jump, acceleration, obviously balance and fall prevention and things like that. I'm very much into that. Any hammer toe, any bunion is going to shift that lever and the digit torque, let's say.
Yeah, yeah, I love that. And you see where we just got to, you guys. We're going to be able to take this right into the Achilles conversation. And
Mhm.
I think it's so interesting how important um and it makes sense, but like how important a relatively small group of muscles are, right? These toe flexors compared to other things like our quads and our glutes and whatnot. But they are so important because of the job that they have in us being a two-legged animal, right? We're up on 2 feet all the time instead of on four, that these toe flexors have a huge responsibility. And like you mentioned, fall prevention, like what's more important than being able to sustain somebody's function and health span late into their years? If we can prevent falls, we can add so many years onto people's life. So it's like there's nobody that's immune to this conversation being important for them. So, what about the Achilles? What we tend to find in our office, and I think in the fitness communities that we're part of, is there are not too many, and I guess I'm using just the chronic overuse variety. There are not too many injuries or pathologies that seem to negatively impact people's function more than chronic Achilles issues, whether that's a runner or that's a CrossFit person or basketball, soccer, you name it. The Achilles really seems to pose a huge problem for people being able to sustain a level of function or intensity of activity, playing with their kids or whatever that they want to be able to do. And we often see so many of these people, they've been dealing with Achilles issues for years, just so many years, and they can't seem to like break past the hurdle of getting past the barrier in terms of like turning the corner on this Achilles problem. Why do you find that that is?
I think a lot of this is based off of the unique anatomy of the Achilles tendon. And because I'm actually quite obsessed with the anatomy of the Achilles tendon, when I do my trainings, I'm like, why is this such a cool tendon? So I want to share that with the
Yeah, let's
listeners.
do it. I think they want to hear it because
Yes. So why? Why?
we've got a
So
very inquisitive group of smart
yes.
people listening to this show. So yeah, I think they would love to hear it.
Awesome. Okay. So the Achilles tendon is the largest, strongest tendon in the human body. This is when we walk and run and do dynamic movement. This is where we get the greatest amount of our elastic recoil. So just a lot of the dynamics of movement is based off of the Achilles tendon, which is important. Another characteristic of your Achilles tendon is that even though it is formed by the gastroc and the soleus, your calves, which is two muscles, it's actually not one tendon. It's two tendons that are stacked and they
Mm,
never interweave into each other to create one tendon. So these two stacked tendons, 2/3 of that stacked tendon, so 2/3 of the Achilles is actually made of soleus fibers. And this is important in how you want to think about addressing Achilles tendinopathy.
totally.
In addition, that stacked tendon rotates on itself towards its insertion. So your right Achilles would do a counter rotation to its insertion, and then your left would do the other way, rotation into it. Yes, so there's this rotation into its insertion. So on your right foot, your, is that kind of rotated? Oh my gosh, can't even think right now. Your right foot, your gastroc is inserting on the outside of your heel. On your right foot, your soleus is inserting on the inside, and then vice versa. So your left one, gastroc is on the outside, soleus on the inside, right? So it's rotating. That rotation, the reason why your Achilles tendon rotates is that it actually decreases friction between the fibers. So we get actually more tensile strength through a twisted tendon. I often give the analogy
Hey,
of like
yeah.
a rope,
Mhm,
right? So
totally.
like a yacht rope. So if you're tying down a boat, those ropes are woven onto each other to make them stronger. Similar with the Achilles tendon. Now, the downside of that is that when you rotate tendon tissue or tissue in general, you compromise circulation.
Sure.
So the Achilles tendon is a very strong tendon because of the spiral, but it's also a tendon that has poor blood supply. You must have good circulation to heal from an injury. That area where you get the weakest point of your Achilles tendon, which is called the watershed area, is where the peak of the rotation is. And that's where you will oftentimes see degeneration. So degeneration of the Achilles tendon, mid-tendon tendinopathy, will occur in the quote unquote watershed area, which is the peak rotation. And this is important. This is an important part of why we see persistent Achilles tendon symptoms. And then just to kind of wrap it up for that is that your Achilles tendon then comes down into your heel and it's continuous. It's one continuous fascial sheath. So I often will see a calcaneal periosteitis, which theoretically could say, is that part of your Achilles tendon still? Sure, but it's very thin fascial based, and then it blends into your plantar fascia. So your plantar fascia is continuous with your Achilles tendon, making them very much influenced and related to each other. And that's why people will say stretch your calves when you have plantar fasciitis, because they're kind of going through that posterior group. So those are, I feel, sometimes understanding the anatomy, why it's such a cool tendon. It helps people to understand where their symptoms are, why their symptoms are, where they are. It also has to do with your foot type can influence that. And then whether you're standing, sitting, technically sleeping, moving, you are stressing the Achilles calf apparatus, which can then just continue to perpetuate those symptoms.
Yeah, absolutely. And I think the folks listening to this show probably know this, but as Dr. Emily was laying out, the gastroc and the soleus are two groups of calf muscles. Just like it does in the tendon, the gastroc forms the outer layer of those, and it's our longer of the calf muscles. It attaches just past above the knee joint. And then our soleus is the deeper, just below, like closer to the shin bone of those calf muscles, and it forms the inner or deeper layer, 2/3 of which on that Achilles. So, like you were getting at, it's important to know how much each one of those different muscles is making up of the Achilles when we start to address Achilles related issues, because so often the soleus is a major component of this.
Absolutely, 100%. I try to get very specific when I see a foot type. So let's say if you have a little higher arch, maybe a little more inverted tilt of the heel, you know that the soleus is a little bit more of a contributor on that. Gastroc, oftentimes I find that the lateral gastroc head is the instigator in that situation. So making sure that I address that. That would also be kind of a quote unquote overpronated foot. You can see more gastroc influence on the Achilles tendon symptoms. So we want to be, the more specific that we can be, the more targeted, the better, not just for outcomes, but because we want to be respectful of the time. And I don't want my patients doing just hours and continuous. It's like they're in this, they're just married to rehab and releasing. And there's some people who I've had patients say, yeah, I spend several hours a day releasing my entire body. And you're like, okay, whoa, time out. That is
Yeah,
clearly, that is not the way that it is intended. And that's probably why you are in a cycle and cannot get out,
totally.
is we want to be a little bit more targeted.
Hmm. So I think when we take note of and we are aware of how um, great and complex the Achilles is, how robust it is as a tendon, and it's the largest one that we have, I think we can understand that when we have an issue with it, well, it's going to cause big problems because it's such a big, important tissue that we have. And it is so strong. Like you mentioned that it's our major elasticity piece, and it absorbs and then can rebound a lot of force. Think of high jumpers, for example. I know there's data out there that's to support that uh, athletes that have longer Achilles tendons, because we're all anatomically a little bit different, are a little bit more predisposed to potentially be better jumpers, particularly in like the high jump variety. Um, but we really need to strengthen this thing when we are rehabbing it, because it is so strong. You mentioned single leg heel raises before. Like, for somebody who is trying to rehab their Achilles, maybe we're using a fingertip for balance or something. Like how many, if someone wanted to do this test on themselves, like how many single leg heel raises should somebody be able to do? If you could just give us a sense of like how strong this Achilles tendon is and like the amount of load that we actually need to use to truly rehabilitate this back to like full function.
Yeah, when I look at exercises for Achilles tendinopathy, is I'm making sure that I'm looking at isometric, obviously eccentric, and there's a lot of research around eccentric loading of the Achilles. And part of why eccentric loading has such a good benefit to the Achilles is it actually is a way to create organization in that haystack. If the listeners remember that, I had said plantar fasciitis has kind of this haystack is disorganized, that by doing eccentrics, you can actually bring organization to the haystack in the Achilles tendon. So that's where it's really nice to do that. Eccentric load actually has to be much higher than people think and a much higher repetition. So that's where you're not doing like 10 reps body weight, but you actually want to get very high repetitions into the dozens that you're doing to really load it. And then concentric would be the last one. So the concentric would very much be the last phase of what you want to train is some sort of power output, because that's where you're then going to be getting, first you have to demonstrate the deceleration moment of it before you can do the positive or the acceleration side. There's the saying that you have to earn the right to jump, right? And you're essentially doing that by showing that you can land. And I very much take that true to any of the rehab that I do with the foot and the ankle is, do you have the foot awareness? Do you have the isometric control? Do you have the eccentric deceleration components? Okay, now you have essentially demonstrated the right to jump or to do concentric. And then once you have the repetition, I also like to do a ball between the heels. So before someone does single leg heel raise, ball between the heel will bring in the posterior tibialis to be part of that exercise, which is good to kind of train the synergist with it. Then, okay, once you have that concentric, now let's do a little bit more ballistic.
Yeah. Yeah, I love that. And I think that's such a cool saying, like earn the right to jump, right? But by landing first, because if you jump, you're going to have to land. So we need to know how to land before we leave the ground. Um, yeah, I think I saw a study that was talking about the strength of the soleus and like the strength of the Achilles. And one of the easiest ways for those of you guys that are listening to kind of isolate the soleus with less use of the gastroc is if you're going to do calf raises or heel raises, we need the knee in a bent position, right? It doesn't have to be necessarily bent to 90 degrees, but you could do a seated heel raise where you have weight on the leg or on the just above your knee. You're sitting on a bench, you have a dumbbell or a kettlebell or something on your leg, and you are doing heel raises to strengthen the soleus. This study said that full, like normal, full strength, we should be able to do 6 reps each leg of 150% of our body weight. And that's like full normal strength of the calf. So, like, as I sit here, I'm just shy of 200 pounds. So I should be able to put approximately 300 pounds on my leg, which you would need a pad to do this because it would hurt your leg to have that much weight on there. I should be able to do 6 seated heel raises. Now, I've not actually done this test. It's pretty much everyone that I know that has done this has used a Smith machine with a pad, and they load up the bar on the Smith machine so that they're not actually having to try and balance this on their leg. But I think it would be an interesting test to try out. But just like Dr. Emily is saying, like we need to do many repetitions because to get back to these repetitive activities, you're going to have to be able to tolerate this load over and over and over again. So just doing 2 sets of 10 single leg calf raises is not going to adequately rehab your Achilles back to the point where we need it to be. And I'm somebody who has dealt with this kind of chronic story of the Achilles tendon, right? In that mid substance, like you mentioned, right? In that like weakest point. And I would say probably the piece that I have done the least of that I'm excited to start implementing after talking to you here is probably that photobiomodulation side of things. I feel like I've done a lot of loading. I've done a lot of integrating the rest of the body. I've done a huge amount of foot strengthening, changing footwear and whatnot. I feel like I've done quite a bit of the put the fire out, let it calm down side of things, including even some regenerative medical techniques to try and improve this, but not a huge, consistent piece of things to promote additional blood flow and healing to the area.
Yeah, and I think that's great. I was, as you were saying this, thinking about 10X.
Yes, that's exactly what I had.
You do
So
that?
12, what is it? It's May. 14 months ago, I had a 10X procedure. So that's TENEX. So it was basically a scar tissue removal procedure to my Achilles to debride some of the damaged tissue that's in there, uh, um, and then laid in with that PRP injection. I've actually had 5 of those in my Achilles. This one involved PRP into the Achilles of a much stronger dose than I had in the past, along with um, PPP, platelet poor plasma, and PRP into a tear that was found in my soleus muscle. So based on the ultrasound imaging and MRI imaging that I had before and after this procedure, I just recently had the follow-up. The tissue quality looks better. What my experience has been is that my Achilles tendon has really thickened over the past several years and even thickened more with this procedure. Now there's probably a lot of more remodeling that's going to continue to take place, but the quality of the tissue that's there and the extent of the tearing and stuff, that all seems to look better on the imaging. Just very thick in the Achilles. And what I have definitely started to do is reincorporate a lot more of this jumping, landing, strengthening, ballistic things. And though it will get sore, it definitely does not feel like it is getting any worse. In fact, it feels like it's getting better the more that I do those things. There's just still a noticeable strength difference and ankle mobility difference between the left and right side that I'm still absolutely working through.
Yeah, no, that's great. That's what I was going to ask you. For the listeners who are probably very intrigued that you have had that, if they've had theirs, is the peak efficacy of those injections, because I do quite a few of those in my office as well, is 3 months. So that's kind of that. So just kind of noting that yours is obviously, I think, a little bit further than that. And then for the listeners to remember that stress ultimately makes us stronger. So you have to stress, back off, allow the remodeling,
Yeah.
re-stress, and it's an art, and that's where it's very hard to be textbook in the recommendations that do this for 2 weeks, do this for 3 weeks. It is an art, and actually medicine is an art. And I try to explain that to patients as well, that if it was literally just this mathematical simplicity that we were very kind of robotic,
Yeah.
then that would be easy, right? And they would keep hearing the exact same thing from every provider, but it is an art, and human beings and connective tissue is just so complex that that is where there is a honor and a respect to your clinical experience of how you see and your navigation and you dancing with the patient of how they respond to certain things and how you navigate that. It's like Play-Doh, and we're molding it a little bit, and the provider that is very in tune with that and continues to patiently follow and mold the patient in a sense is the one that is actually going to be getting the results. Those that follow a template, and if they don't respond based off of a template, they're kind of like, I don't know what to do. That's unfortunately what a lot of people are experiencing in modern medicine.
Yeah, man. Yeah, and I had a conversation earlier today with a primary care provider who practices exactly the opposite of what the typical medical office is, and that's exactly what we sort of talked about was, you know, individualizing things to the person and not just continuing to throw the typical book-based treatments at symptoms that they have. Before we start to wrap things up, you had started to allude to this with the doing heel raises with the ball between the heel to incorporate and integrate the posterior tibialis muscle. And we know that that's highly involved in controlling the amount and the rate at which our pronation happens, and oftentimes is linked to this shin splints or medial tibial stress syndrome. So when somebody is presenting with like pain down around the inside of the ankle or in the lower half of oftentimes the inner medial side of the shin. And they've been diagnosed by either their coach, their podiatrist, their physician, whoever that might be, the running store clerk or employee, and told that they have shin splints. We often see that an orthotic is often prescribed, or a motion control shoe, something that controls pronation.
Mhm.
Is that the typical approach that you would take? I have a feeling it might not be based on the conversation we've already have, but like, what is the way that you start to go down this conversation when someone's dealing with these medial tibial stress or shin splint related complications?
Yeah, so a lot of this goes back to the impact vibration story that I was saying with plantar fasciitis. Is uncontrolled vibrations are going to go through your tissue, it's going to go through your bone, and you do not want bone to vibrate excessively. Controlled vibrations through bone is actually how you stimulate osteoblasts, which are the cells that build bone density. So vibration is good for bone, again, controlled. So excess vibration because of a slow foot, a disconnect from the ground. So sometimes people get shin splints because they have no perception of the ground and their foot strike pattern. So that's one thing that I think about and say, okay, we need to tune you into your feet, to your movement. I need you to feel vibration. I need to understand how to contract your muscles around vibration. That's sometimes the story, right? Sometimes it is the foot strength, the foot type, the loading response is just being overloaded because maybe they're running on concrete. I don't
Yeah.
know. So I'm just, that's another factor, right? So it's just another consideration. Maybe it's overpronation, but is it just that they need to accelerate the deceleration moment of that overpronation? So could that be done through exercises and programming and like glute strength? Maybe, right? Or is there some ligament laxity that is controlling or creating the overpronation, which is creating internal rotation of the tibia? And there is some research showing that shin splints is very much correlated to uncontrolled internal rotation of the tibia. So it's more of a torsion injury or a transverse rotation injury. So that's where I would factor it in. So I couldn't answer that and say, for sure, I'm going to be prescribing, you need orthotics. I need to know many things in that story, which is why it's always hard to give recommendations through like a quick inquiry on Instagram because
Totally.
there's a lot. There's a lot. The person is way too complicated. And just in case some of the listeners might be thinking about like compression sleeves with shin splints, where I would recommend compression sleeves for shin splints is that part of how you damp vibration is through compartment pressure. And by using a compression sleeve, you will increase the pressure in your lower leg muscle compartments so that the muscles don't have to contract as fast. So that's a way to manage, prevent, mitigate shin splints based off of timing of that stabilization response.
Yeah, that's an interesting way to look at the compression sleeves or socks as a dampener of the vibration through pressure. That makes good sense. And I like what you just said about how, it is so hard to give like kind of blanket quick recommendations for people, whether it's on Instagram or however else they might reach out to you, because it is just so complex and integrated or like intricate when we're dealing with these issues because two people or 10 people could have the exact same symptoms, but why one has it compared to the other one, or what we're going to decide to do about it, and in what order we're going to do these things might be different. It might be a different combination of things. It might be totally different things in general. One person we might want to refer out for imaging because something they told us in their story screams, maybe you have a stress fracture. This does not sound like shin splints. Maybe this other person does need the orthotic to calm things down. And and just, I think hopefully the people listening to this know this, but just to throw this out there, like the reason that Emily or myself or any other provider hopefully would tell you, hey, I just can't give you these like general recommendations. Like, I would like to see you for an appointment to figure out like what is going on. It's not because we want to charge you for the appointment. It's because we want to make sure we're giving you appropriate recommendations for you and not just like giving you some general random things that might not actually fix your issue could make it even worse if we don't know exactly what we're dealing with. So it's really more about protecting you than about the cost or anything like that.
Mhm. Yeah, absolutely, absolutely. And I think part of that is under the Hippocratic Oath of
Yeah,
not
totally.
doing it anymore, which I take the Hippocratic Oath very seriously. And some providers unfortunately get a little skewed from that. But right, we want to make sure that any recommendation, especially a general recommendation, actually doesn't, let's say in plantar fasciitis, I suggested something without understanding the whole picture, and then they ruptured their plantar fascia. Like I don't want that on my shoulders because of not having the true full story.
Yeah, absolutely. Well, as far as vibration goes and ground reaction force and things, just one thing that I tend to find anecdotally that is very common, I think, with the shin splint sort of variety or the client coming in the office with shin splints is it is pretty rare when I find a person, we'll use a runner, for example, or a walker that has a high cadence and a shorter stride that tends to suffer a lot from shin splints. It is often the exact opposite. It's often the overstrider, the big time heel striker, person that's hitting the ground harder, thereby creating more vibration, like you said, Emily, that is often leading to these types of things. And when we can control the amount and the intensity of that vibration that's happening, we're often able to mitigate that quite a bit more. So just take that for what it is. If you're someone that does suffer from shin splints and you've not had a thorough assessment of like what's going on, whether that's a nice deep gait analysis or a functional assessment of some sort, that would probably be a smart next step as opposed to the over the counter typical massage the calf and whatnot things, compression sleeves that don't necessarily address why it's happening in the first place, though they might be helpful in controlling the symptoms.
Absolutely.
Before we wrap it up, Emily, I would just love for you to, as deeply or as briefly as you'd like to, just mention Naboso and talk to us about what Naboso is. You had mentioned the sensory integration piece early in the conversation, and then we'll tell people where they can find you, and we'll let you enjoy the rest of your afternoon.
Sounds great. So yeah, Naboso is a sensory product line, and we use texture as our sensory stimulus. On the video, you will see that I have one of our neural balls, and there's pyramids, little tiny pyramids across all of our products. Those pyramids are stimulating the nerves in the bottom of the feet and technically the palm of the hand. So it's called mechanoception or touch. Texture, 2-point discrimination is a very specific sensory stimuli. The goal of all of the products at Naboso is to increase awareness of our feet, our foot posture, our movements, to also strengthen and wake up the muscles. They increase circulation, and they are an awesome form of recovery. So at Naboso, we have textured socks, insoles, release tools, mats, we have flooring, a full product line that allows you to really elevate your movement experience from the ground up, feet first, using that sensory stimulation.
Yeah, I love it. And I couldn't give you guys a big enough glowing recommendation. I have several products from Naboso. I have numerous pairs of shoes that have a couple different varieties of the insoles in them. I think they're awesome to walk around in. I have one of the standing mats that Emily actually sent over to us the last time we did a podcast recording, and then I have we have some of the neuro balls in the gym where our office is located that we get to play around with, and then a pair of the toe spreaders that you guys call splay. I love to wear those around, and I have found, I know you can find toe spreaders, you guys, all over the place. I have found the splay ones from Naboso to just simply be more comfortable than some of the other ones that I've ever worn and more durable. So I think they're totally worth it, and I couldn't recommend them enough. When you guys go to the website to check out the products from Naboso, use the coupon code Dr. Andrew Fix, my name, to get a small discount, and hopefully you enjoy the things that you decide to try out. Awesome.
Awesome.
That being said, Emily, where can people find you online if they have questions, if they need to find a provider like yourself for anything foot related that they've got going on, or if they want to go to Naboso? What are the best places for our listeners to find you guys?
Absolutely. So my website for my practice, my podiatry practice, is my name. So dremilysplichal.com. look in the show notes for that. And then I do see patients virtual. So I am direct access. So I'm not under insurances. But I spend an hour with every patient, whether it's virtual or in person. My in-person office is in Arizona. So see patients that way. I do regenerative injections if that's needed as well. I am on Instagram, which is very educational based. So if you want to learn some stuff about the feet, my handle is The Functional Foot Doc. So you can follow me there. For Naboso, our website is naboso.com, naboso.com. And then we are on Instagram, Naboso_technology. I am on YouTube. It's probably easier to just search Dr. Emily Foot and you will get hundreds of videos. And then I wrote a book called Barefoot Strong, which is on Amazon. And I have a book, my second book coming out in July, which is around movement longevity. So check those out.
Awesome. Well, thank you so much again, Emily, for joining us. You guys will put all those things in the show notes, the links to the websites and everything, and the social media pages. So be sure to check those out. Check out Naboso, get some things for yourself, and spend some time getting your foot integrated to the world. Get out of those shoes and strengthen your feet. And if you've been listening to this this podcast before, we really appreciate you tuning in for yet another episode. If it's your first one and you've not already left us a review on this show, that would be huge. We're trying to get the messages and the interviews here out to more and more people. And we have a goal of getting up to 200 5-star reviews on this podcast. So whatever platform you're using to listen to this, please scroll to the review section, drop a review on there, and then we'll be sure to catch you on another episode of The Code. Thanks so much, guys. Thanks, Emily.
Thank you.